Hello dear viewers, in this video which is part 11 of continuous renal replacement therapy, I will be discussing part 5 of renal citrate anticoagulation where I will discuss complications associated with this therapy. Specifically, I will discuss electrolyte disturbances during renal citrate anticoagulation. It is important to understand details of complication since it impacts management and ensure safety efficacy of CRRT therapy. Hypocalcemia during renal citrate anticoagulation occurs as citrate in the extracorporeal circulation chelate ionized calcium to form citrate calcium complex, part of which along with some of the unchelated ionized calcium will be lost in the effluent through the semi-permeable membrane. If calcium is not properly replenished, hypocalcemia will occur. Hypocalcemia reduces myocardial contractility, induces arrhythmia, tetany, and other systemic symptoms. However, these complications are relatively easy to detect and manage with standard monitoring. It is recommended to monitor the ionized calcium concentration in the filter and the blood in the body at least every 6 hours. Total calcium and total calcium ionized calcium measurement are recommended once a day for patients at low risk of citrate accumulation and every 6 hours for patients at high risk. Similarly, ionized magnesium can also be lost in effluent. If the lost ions are not properly replenished, hypomagnesemia will occur. The requirement for magnesium supplementation depends on composition of the replacement fluid or dialysate being used. Thus, it is recommended to measure serum magnesium once a day. By following standard regional citrate anticoagulation therapy protocols and monitoring blood calcium levels, hypercalcemia is less likely to occur. In a situation like citrate accumulation, increasing the amount of calcium supplement because of decrease in vivo ionized calcium is likely to cause high total calcium and low ionized calcium level. This condition should be managed as I discussed in my previous video where I discussed about citrate accumulation leading to metabolic acidosis and its treatment. The impact of altered sodium ion concentration caused by CRRT treatment needs to be considered in advance, especially when using regional citrate anticoagulation. It is important to understand that increase of sodium ion may be more obvious in patients with hyponatremia, or the higher sodium might be beneficial to control brain edema. Sodium concentration in 4% trisodium citrate solution or ACDA is much higher than in normal serum. There is risk of hypernatremia from prolonged or high dose citrate anticoagulants. However, hypernatremia is uncommon when following a standardized protocol. If hypernatremia occurs during regional citrate anticoagulation, blood sodium concentration can be reduced by increasing the replacement fluid or dialysate flow rate to allow more sodium clearance through the semi-permeable membrane. There is generally no need to reduce the citrate flow rate or adjust sodium concentration in the replacement or dialysate fluid. However, the uncommon occurrence of hypernatremia during RCA is based on the relatively low sodium concentration in replacement fluid, means in the range of 1:110. But if fluids with the higher sodium concentration is used, for example 140 millimole per liter, isoosmolar citrate solution could be used as I discussed in my previous video about trichmocitrate instead of ACDA or 4% trisodium citrate in case hypernatremia occurs. In brief, hypernatremia is not a contraindication for using RCA or regional citrate anticoagulation. However, the effect on patients caused by the change of sodium concentration should be considered before applying. Here I finish. Hope this video is useful to understand the nuances of regional citrate anticoagulation. If you have any questions, please write them down in comment section. See you in my next video on CRRT. part 12 and regional citrate anticoagulation part 6, where I will discuss contraindication of regional citrate anticoagulation. Till then, bye and take care.